So I think that one of the expanding uses of 3D echocardiography is also to look at the valve prostheses, particularly prostheses that are in a mitral position. And the good reason for doing that is that with 3D we are able to look at the valve from the atrial side, and this is the preferred view using transesophageal to detect issues that are going on. As you know, we have two type of surgical procedures on the mitral valve. Basically, that is the mitral valve replacement that may be with a mechanical prosthesis like in this slide, with a B-leaflet prosthesis, or a repair with annuloplasty, and usually with a prosthetic ring. And it's quite interesting to see how detailed can be the visualization of the ring, and even the knots that the surgeon stitches to take the ring in place. As well as for the prosthesis, particularly the mechanical prosthesis, you can have a detailed analysis of the occluders, as well as on the hinge mechanism, and of course of the sewing ring. It's not, the concept is not new. This Roberto, I'm quoting Roberto, that in 2011 already wrote that 3D echo supplements to the echo prosthetic valve evaluation, allowing the visualization of the valve from any orientation, specifically through the additional unfaced view, highlighting the added value of a 3D echo in assessing the prosthesis. Not only, but the current technology, we can have also the side-by-side displacement of the anatomy and the flow to be able to make a relation of the morphological alterations and the resulting defect. This is just a small residual regurgitation that I have put here just to show how sensitive may be the color and how you can identify and localize the origin of the jet. But as Mark pointed out, you are here to see what was wrong, and this is something that is always attract people. So this is the first case. This is a lady who was implanted with a tilting disc valve, and she developed several episodes of AAT, and on the two-dimensional echocardiography there was nothing strange, but after a recurrence of the AAT, we performed an additional transesophageal, and this time we were able to image the valve also with the 3D. And you see that there are of course a thrombosis of this B-leaflet prosthetic valve. There are several thrombi that you can identify. There is one that is going up and down here inside and outside of the orifice, but there are also other mobile structures much smaller that are here. And also looking at the valve unface, you can realize that there is a sort of flat thrombus on this hinge mechanism. And also, as you can notice, we cannot see anymore the knots of the stitches of the surgical stitches, and this is a sign of the pannus overgrowth around the prosthesis. And indeed, both of the these findings were confirmed at subsequent surgical intervention. There is this large pannus that was removed, and also the remnants of the thrombi. This is another case of B-leaflet mechanical prosthesis with a non-obstructive thrombus. The thrombus can be also seen quite nicely at the 2D imaging, but if you want really to appreciate the localization and the extensions, that means the sizing of the thrombus, that may have implication for the indication of a surgical or this is not the case because it's not obstructive of a thrombolytic therapy. When it is obstructive, this is the view that you have to obtain, the unfaced view from the atrial side, being able to imagine the location and the extension of the thrombus. This is what the prosthesis looks like, and this is after 2 weeks of aggressive anticoagulation. And you see that now both on 2D but also on 3D the prosthesis looks quite clean, with a free excursion of both the occluders that you can nicely see over here. This is a more complex case, because here you have a stuck disc that is also confirmed here at the 2D imaging. We were unable to identify any thrombus over here, but you can appreciate this huge pannus overgrowth that has also entered into the supposed orifice and was likely the cause of the blockage of the occluder. Of course, with these images, there is no room for anticoagulation anymore, but the patient should be sent to the cardiac surgery to avoid the likelihood of a complete blockage of the prosthesis. This is another case of a stuck leaflet, but in this case there is an obvious thrombus seen here. Then also there is something wrong over here, so there is a small thrombus also on the other hemidisc. This is a quite risky situation because there is an impending blockage of the prosthesis. The patient should be evaluated if there is the case of going to thrombolysis, or the patient if the overall clinical conditions are suitable for redo surgery that should be urgent surgery. This is one of the largest thrombus that I have seen on a prosthesis, one of the largest, not the largest, and you see the huge amount of the thrombotic mass almost occluding this prosthetic valve. I told you that this was one of the largest because this is, by the way, the largest one. I was called in the emergency, in the intensive surgical room, and say, okay, this night we have finished a mitral valve replacement, but now the patient is hypotensive and doesn't do such well. And I have never seen something like this in my life. This is a huge thrombus that is almost filling the entire atrium, and this is the residual motion of this poor bioprosthetic valve. And of course, after I was not believing at my eyes when I have seen that, and they tried a rescue surgery, but unfortunately the patient didn't survive. Other possible complications are, of course, ring detachment. This occurs quite frequently, unfortunately, and these are nicely seen and nicely diagnosed using, again, the unfaced view. You see the ring, and in the background, the leaflets of the mitral valve, and you see this area of detachment. Here in this patient, the area of detachment is much larger and requires quite consideration from the surgeons. One of the expanding areas of the use of a three-dimensional echocardiography is to detect and sizing the detachment of prosthetic valves. You know that in these patients, and we have discussed it this morning with Pepe Zamorano, how effective can be the interventional closure of these perivalvular leaks, and this is mainly due to the fact that the redo intervention on these patients has a quite high mortality in the range of 12-20%. So, and another point underlined by Pepe Zamorano was that not only the size of the perivalvular leaks, but also the position as an important parameter to judge about the feasibility and the likelihood of success of the procedure. Well, putting together volume rendering and color of a 3D color, you can nicely identify the position as well as the sizing of these perivalvular leak. And of course, you can guide the procedure, but this was already been explained by Pepe Zamorano. Sometimes things are not so easy to detect. This was a mitral valve-in-valve procedure. The procedure is very easy because they have the guidance of the ring of the previous prosthetic valve, and so they put a sapient valve, like in this case, and just blow out, and the procedure is finished. But in this case, the patient was not doing that well, and it was not clear what happened. And we perform this 3D transesophageal echo to see that for some reason, not all the leaflets were moving in the correct way. This one was stuck, and we were unable to understand the mechanism of that. And indeed, it was quite strange to see this leaflet stuck in a bioprosthesis. And so what we did to check that it was not just a false image was to make a longitudinal cut of the valve to image the leaflet, and to realize that indeed that was a non-moving leaflet, and so the patient required a further ballooning of the valve. These are the last two cases. This is I can define these cases when the cardiac surgeon doesn't listen to an echocardiographer. This is the result of a restrictive annuloplasty on the tricuspid valve. This valve was a huge annular dilation with a huge tenting of the leaflets, and this was nicely shown before surgery, but they were so stubborn to put this downsizing annuloplasty without making any elongation of the leaflet. And the results, of course, was an even higher tenting of the leaflets and even more severe regurgitation than before. And sometimes they really are stubborn, and this is the result of trying to restrict a huge tricuspid annulus. And so you will end up in the detachment of the annulus, and again a huge regurgitation. Or if you wanted to have a really competent valve, you restrict and restrict, and in the end you will result in a tricuspid stenosis without solving the regurgitation. But again, these are nicely seen here. I think really that there is an added value of 3D echocardiography to assess a surgical procedure when there is something going wrong, and this is related to the fact that we can cut the data set in any view. So we have an unrestricted stereoscopic view of the prosthesis, and particularly they are in motion, so we can assess not only the function of the prosthesis but also the relationship with the adjacent structures. However, and this is the drawback, sometimes the images are not that easy to be interpreted, so we really need a specific expertise of the operator, and last but not the least, you should know exactly the surgical procedure that has been performed to provide a correct interpretation of your findings. Thank you very much for your kind attention.